Tarsal tunnel syndrome. So what is the tarsal tunnel? The tarsal tunnel is a fibroosseous tunnel posterior and inferior to the medial malleolus. The tunnel is covered by the flexor retinaculum, which protects the structures contained within the tunnel. The flexor retinaculum is a thick ligament that runs between the medial malleolus and the calcaneus. So what is inside the tunnel? The structures which pass through the tunnel include Tom, Dick, and Harry. It is the tibialis posterior, the flexor digitorum longus, the posterior tibial artery and the tibial nerve, and the flexor hallucis longus. We are interested in the tibial nerve, which lies between the posterior tibial artery and the flexor hallucis longus. Tarsal tunnel syndrome is a compression neuropathy caused by compression of the posterior tibial nerve within the tarsal tunnel. It is the most common compression neuropathy in the ankle and foot. Thickening of the flexor retinaculum may cause compression of the posterior tibial nerve. Causes of tarsal tunnel syndrome. 80% of the cases are associated with a specific cause. The causes are multiple, and it includes a space-occupying lesion such as lipoma or ganglia, varicose veins, muscle anomalies, history of trauma, tenosynovitis, rheumatoid arthritis, diabetes, malaligned foot. Symptoms of tarsal tunnel syndrome: burning pain, numbness, tingling, and electric shock sensation, typically in and around the ankle or at the bottom of the foot. Typically, it is at the plantar aspect of the foot. Symptoms are worse with activities such as walking, standing, or running. The symptoms are relieved with rest and elevation. The pain associated with tarsal tunnel syndrome may be worse at night. There may be swelling around the ankle and the foot. Examination. The patient will have a positive compression test and a positive Tinel's sign. Tapping on the nerve posterior to the medial malleolus causes radiating pain into the medial side of the ankle and possibly to the foot. Pressure within the tarsal tunnel increases with ankle dorsiflexion and foot eversion. This may reproduce the symptoms. Pain associated with tarsal tunnel syndrome could radiate proximally and distally. Tarsal tunnel syndrome may be present as part of the heel pain triad, which occurs in adults. The heel pain triad includes tarsal tunnel syndrome, plantar fasciitis, and acquired flat foot deformity. The flat foot deformity will increase tension on the nerve. EMG and nerve studies. Combination of history, examination, and EMG and nerve studies can lead you to the diagnosis. History is the most useful examination. EMG is accurate in about 80 to 90% of the time. Dorsiflexion eversion test is described to be helpful in the diagnosis of tarsal tunnel. The sensory nerve conduction studies are more helpful than the motor studies. Always rule out radiculopathy. Radiology. Radiograph and CT scan may show the osseous impingement or a posteromedial process fracture of the talus. The MRI may show a space-occupying lesion such as a ganglion cyst or a lipoma. Differential diagnosis. Peripheral neuropathy. It involves all the nerves, not just the tibial nerve. You will find that the sural nerve, the saphenous nerve are also involved, and there will be absent ankle jerk. Treatment. immobilization, anti-inflammatory medication, and steroid injection. Patient may have orthotic with medial posting if the patient has a valgus hind foot. Surgical release of the tarsal tunnel if non-operative treatment fails. After a trial of 3 to 6 months, you will release the fascia proximal to the flexor retinaculum. You will release the flexor retinaculum. You will identify the tibial nerve proximal to the tunnel, and you will decompress the nerve and its 3 branches. You will decompress the entire tunnel 5 cm proximal to the flexor retinaculum and distally to the deep fascia of the abductor hallucis. The distal release of the baxter nerve is usually done if the patient has chronic plantar medial heel pain. Heel pain is uncommon in tarsal tunnel syndrome. Again, you will decompress the baxter nerve by releasing the deep fascia of the abductor hallucis. You will remove any space-occupying mass. The best result occurs if symptoms occurred in less than 1 year. A successful outcome occurs in about 50 to 90% of cases. The best result occurs if the patient has a space-occupying lesion with positive physical examination and EMG findings. The suboptimal result can occur from inadequate release, or if the patient has traction neuritis and repeat tarsal tunnel release. In these situations, the patient will not respond well to surgery and always rule out double crush syndrome. Revision surgery have a less successful outcome unless the patient has inadequate release. Recurrence of tarsal tunnel syndrome is usually caused by inadequate release, and repeat tarsal tunnel release is usually not advisable. In general, tarsal tunnel decompression may not produce a good long-term outcome.